Thank you for joining us at the end of a long week and probably a long day. My name is Kat Ogle. I am an associate professor of emergency medicine at the George Washington University in Washington, D.C. And I am very excited to be chatting with you today about a practical framework for recognizing and approaching sexual harassment in academic emergency medicine. So I'd like to start by acknowledging that the group that you see in front of you has put this together. We're not sexual harassment experts. We've not built our careers around doing research on sexual harassment. However, we are all academicians, and we recognize that we have an important role to play in defining how we should be approaching this in academic emergency medicine. And we'll be looking at this from the perspective of our learners, our colleagues, and sometimes our patients as well. It's also important to recognize that there are some caveats to this topic, and this is not an all-encompassing approach. And there will be some things that will not be discussed because they're sort of out of the scope of this session. But what I want you to think about is what can you learn today that you can take into your practice when you go back to your organization? All right, so this is really kind of getting you to think about what structures currently exist in your organization, and how can you make a meaningful difference for your learners, for your peers, and the like. So our team, I'm just going to ask everyone to introduce themselves briefly. We'll start with Dr. Walker.
I'm Laura Walker. I am at Mayo Clinic in Rochester, Minnesota.
My name is Moon Lee. I'm a clinical associate professor at Stanford.
Hi, I'm Namita J. Prakash. I'm an EM critical care physician at Henry Ford in Detroit.
And I'm Michael Cole, emergency medicine physician at University of Michigan.
And then we have...
I'm Jim Miner, chair at Hennepin.
Ava Pierce, UT Southwestern Dallas.
Thank you. So none of us have any disclosures to discuss. So why did we get here? How did you find us in front of you? And what has gone on is that the SAEM Board of Directors and the Faculty Development Committee realized that there is a gap in knowledge for our entire membership around this topic. And so we were charged with 3 specific aims. Our first was to develop a position statement. And so if you scan the QR code, you can actually go directly to the SAEM position statement on sexual harassment and misconduct. Our second aim was to create an educational webinar, which you can find on YouTube. If you go to the SAEM channel, you'll find our webinar. And that was delivered 3 weeks ago. And then the final step was to put this didactic together and really do it in an interactive way. So we actually have some cases to go through to get you kind of thinking about, again, how are you going to apply the concepts that we're going to be discussing today? And because this topic can be particularly emotional or triggering for some individuals, we've also created some space at the end of the didactic, another sort of mini didactic in which we can do a structured debriefing for anyone who cares to stay around. These are our learning objectives. You can find them in the planner, so I'm not going to read them for you. But again, we're going to be talking about this from the perspective of a learner, a colleague, and a patient.
I'll start off tackling the first big question here, which is the definition of sexual harassment. And it's one that it gets fuzzy for people, and it's not always clear what is encompassed by that. When we are doing this talk, sexual harassment and sexual misconduct are really used as umbrella terms and are inclusive of sexual violence and gender-based harassment. And the important part here is really the underpinning of what constitutes sexual harassment is that is unwanted or unwelcome approach to someone, and that the victim's perspective is absolutely paramount in that definition. So, consider the difference between making or receiving an unsolicited sexual comment versus open and establishing consensual boundaries to a relationship. If you don't know where you are, you're going to fall into some territory that could be problematic. Power differentials are another complexity that's layered in here, especially in a learning environment, a hierarchical academic environment, all those things. As physicians, we're leaders of the team. We work with all the learners in their different hierarchies and situations that the power differential is less obvious, but may be felt by one party. So this is kind of the definition that we used here, which is from the U.S. Department of Education. Sexual harassment is unwelcome conduct of a sexual nature. It includes unwelcome sexual advances, requests for sexual favors, and other verbal, nonverbal, or physical conduct of a sexual nature. And again, we get kind of into suggestive statements, dirty jokes, locker room talk, things that you might not ordinarily think of qualifying as sexual harassment absolutely can fall under that umbrella. Consider also electronic communication, so texting, DMs, sending unwanted messages to people is something to be very aware of also. Sexual violence is absolutely under this umbrella and is a form of sexual harassment, kind of the extreme end of things, but is included in all of this. Additionally, we have increased awareness about the importance of supporting diverse gender identities. We haven't seen a lot of discussion on this in particular, where disrespectful behavior towards individuals with regard to their gender identity or expression has been explicitly identified as sexual harassment. And again, it is absolutely included under this umbrella. And it's important to remember that harassment is determined by the perspective of the victim, not on the intrinsic beliefs of the accused. So considering gender identity, gender expression, transgender individuals, non-binary or genderqueer, or even stereotypes that are applied to cisgender individuals as well.
All right, we're also going to go through some specific examples, and I think what's really important here is to remember that it's from the perspective of the person who's receiving it. So if they don't perceive it as unwanted behavior, then it's not necessarily sexual harassment, because some of these examples you might think, wait, I've done that. Was that sexual harassment? And so we're going to go through some specific examples. All right. I think the first example here is kind of commenting on how a person looks. So saying like, oh, you look so nice today, which may be unwanted, or I like how that shirt looks on you. Those are kind of unwanted comments, sometimes in the workplace environment. So you just have to be mindful of that. And if someone tells you, I didn't appreciate that comment, or I don't like those comments, then you should probably stop. Otherwise, it's considered sexual harassment. Other things are kind of commenting on the physical appearance of your colleagues, maybe not directly at them, but to other people. This can create an environment in which people think that maybe sexual harassment is tolerated. I think also just talking about like your own personal experiences, that might be something to avoid, because otherwise people may perceive that as sexual harassment. Like no one's asking you about like what you did over the weekend or what your experiences were over the weekend. And if you start bringing it up, people could perceive that as sexual harassment. Or talking about other people and assuming that they need to have a sexual encounter to be happier at work. And that is also another form of sexual harassment. Some examples that you might see through text, you may be invited by a colleague or a coworker to go out for drinks, but also implying that something else might happen. I mean, I think we've all been in the dating pool, and sometimes this is welcome, but other times it's not. And if the person says no, that's pretty much no. It's not welcomed behavior and should stop. Also, sending pictures that you know it's not appropriate for work, and you probably wouldn't want your family members to see it, then you probably shouldn't send it at work. Otherwise, it could be considered sexual harassment. Spreading rumors about other people, about why they have certain positions, or what they may or may not have done to get those positions, can also be considered sexual harassment. And then just asking other people about their personal experiences and sexual activities is not appropriate.
So then we get into the conversation about what do we do when this happens. And so I'm going to tackle these in a couple of different ways. I want to first talk about Title IX. I'm sure that you all have heard of Title IX, but essentially it is legislation that was put in place in 1972. And it was put in place specifically to protect people who are in a learning environment from any sort of sexual discrimination or sexual harassment or violence. And it is created so that any institutions that are receiving federal funds They are obligated to respond and create safe spaces and respond in an appropriate way if they get a hint that any sort of sexual harassment, discrimination, or violence is occurring. In order to be able to maintain these systems, there's an expectation in those organizations that they have some sort of a mandated reporter. Now, a mandated reporter may be called a different term in your organization. I'm just going to use the general umbrella term mandated reporter as the person who is employed by the organization who, if they hear something happens, they are required to report it to the Title IX office. All right, because then the Title IX office takes it from there and pursues an investigation, and we'll get into that a little bit more. As I said, the title of this mandated reporter may vary from institution to institution, and it also may vary between who's actually responsible for reporting. In my institution, for example, anyone who is employed by the university, whether it is an environmental service worker or the dean of the medical school, is a mandated reporter. If they see something or hear something, they are to report it to the Title IX office, and they're supposed to take care of it from there. There are other institutions that have only certain tiers of employees will have it, so it may just be educational leadership or departmental leadership. So you have to look at your own institution and see who your Title IX ombuds people are. Now, once a report is made to the Title IX office, the Title IX office then pursues an investigation. They will reach out to the victim, the person who was discriminated against or harassed, and they will reach out to that person for a couple of different reasons. Number one, they want to reach out to that person to give them resources because this is a traumatic event, and they want to make sure that they have the support that they need to deal with the psychological ramifications of this event. Number two, they want to identify where the problems are, okay? And that may require a comprehensive investigation, which includes the person who was harassed, but that person who was harassed has ultimate autonomy for deciding whether or not they want to be part of the investigation. Now, even if a learner does not want to be part of the investigation, the Title IX office still pursues it and collects additional information in that department around the individual that is reported as the instigator. And so it's not that nothing happens, it's just that we always want to preserve the right and the autonomy of the person who has been harassed. This is a complicated topic, and this will take you to the Title IX basically fact sheet, and it'll give you a couple of different ways to approach this and different ways to think about this. But the core of it is your ultimate responsibility as a Title IX bound organization, educational institution, is that you have to recognize when sexual harassment is happening. You have to institute protections for your survivors. You have to make sure that you are responding in a timely fashion to any incident. You are forbidden as an organizational institution or an educational institution from pressuring the survivor to participate in an investigation. So you can't coerce them and push them into participating in an investigation. If they choose not to participate in the investigation, that is fully in their right. The other thing that this is supposed to do is it's supposed to create a space in which the survivor never has to come face to face with the perpetrator again. And so if it's if it's a clinical elective, that may mean that you as an organization have to change that person's rotation so that they do not have to come in contact with this person. So there are multiple layers of complexity that go into this, but that's one of the other things that is in this Title IX fact sheet. The last part of this is, and I think this is probably one of the trickiest things that we're not really going to get into a tremendous amount today, is that the survivors are supposed to be protected from retaliation. You probably are aware that the likelihood of someone reporting is directly dependent on their perception that there's going to be some sort of retaliation. And so it's really, really important to ensure that your organization has those layers in place to protect the survivors from any sort of retaliation. And it's incumbent upon us as leaders in academic medicine to pave the way. So when we get into our workplace as faculty, it's a little bit different. Now, we do have some protection by the Equal Employment Opportunity Commission, and there are some laws that protect us there. And I'm sure you've seen verbiage on your department, probably your department's website about non-discrimination, and whatnot. So many organizations will have either a grievance process or an ombudsman process. And so oftentimes the grievance process goes by chain of command. You report to your direct supervisor, and then it goes up the chain of command, and they figure out how to deal with it. You may alternatively have an ombudsperson. And so my challenge to you, and what I want you all to think about today, is if this happened to you or this happened to a colleague, who would you reach out to? What is the process in your department? Because I can't tell you what it is. It's vary from organization to organization. So you'll have to figure out what it is in your site. And again, the whole point of this is trying to create a safe space for people who are harassed. And as I mentioned, sometimes there will be an anonymous reporting system in place. Again, you may have a direct supervisor that you can connect with, but if you don't feel safe with the direct supervisor, then where do you go? What are your options? You can always go to human resources, and that's a different pathway. And one of the things that is challenging about the human resources pathway is once it gets into human resources, it sort of goes into this black box, and then you are no longer aware of what's happening with the person who's accused. And part of that is a protective measure. So just as you, as a person who has potentially been harassed, has autonomy and are able to have the respect of confidentiality, the person who's accused also has those same rights. And just because we may perceive that nothing has happened when things go into the HR office, there are still things that happen, and there are generally patterns of behavior which are identified by leadership and can be leading that person into some sort of a remediation plan or some sort of counseling, and it's just not something that's going to be privy to you as, or to your colleague as the victim. So what do we do if it's a patient? I am sure that everyone in the room has probably seen that situation where a patient was inappropriate with a doctor, inappropriate with a nurse, inappropriate with a respiratory therapist. And many times we sort of chalk this up to, it's just part of the job. You just have to deal with it. You just have to suffer through. And, you know, that's one way to approach it. We would challenge that that's actually not the right way to approach it. And there are a couple of different things to keep in mind. Of course, we're emergency physicians, and we want to make sure that we're taking care of patients appropriately, but we also have to make sure that we're maintaining the psychological and physical safety of our staff and our learners. So the first thing is make sure the scene is safe and engage your hospital security. The next thing is talk to the patient and draw some boundaries. If that patient is not critically ill, they can have a choice. They can leave, or they can follow certain appropriate behavioral guidelines. You can create a behavioral contract, and if they violate that behavioral contract, then the next step is to have them exit the building. Now, if they are critically ill, it gets a little bit more complicated. You have to think about EMTALA. You have to think about if they cannot behave in a certain way, what actions are you going to take to maintain the safety of your staff? Now, there's a nice little flow diagram on what to do. Scan the QR code, that will take you to this PDF because this is really hard to see on a screen. But it essentially says, do you feel safe or not? As you go down that pathway. So if you don't feel safe, find a way to get out of the room and ask for help from a colleague or a supervisor. If once you've done that, you can file a report with leadership, and then the next step is consider transferring that patient to another person's care. Or place a warning in the conversation with the patient or in the chart. So we're going to go into small groups. We have a relatively small group as it stands here. And we've got 3 different cases that we're going to go through. One of them is a learner, one of them is a colleague, and one of them is a supervisor, a supervisee position, a subordinate position. And I want to sort of lay the groundwork here that I acknowledge that this can be a challenging conversation, and so I thank you for coming in the room to actually have the conversation first and foremost, but we also want to acknowledge that there may be some strong feelings that come up, and so we are here to support you. As I said, we have a debrief after if you need it, but the other thing is these cases are fictional cases. Any similarities to existing events are purely coincidental. What was the
Law and order.
Law and order? Yeah. Okay, so these are not real cases, but they were developed by folks who span the gamut in SAEM, and so we hope that we have some inclusive representation. So when you go into your small groups, we're going to ask some prompt questions and kind of get the group thinking about it. And I really want each of you to think about it from the perspective of your own institution, because there's going to be some variability from person to person. So if you were in your institution and this happened, what would you do? What would your response be? How would you engage with this individual? How would you counsel this individual?